Thank you for the introduction. And again, thank you for having me at this great conference. My talk is about oligometastatic pancreatic cancer, evidence-based treatment strategy. And I do not have any financial disclosure. So if I would stick to the title, I would probably will end up my presentation by saying that there is no evidence-based treatment for oligometastatic pancreatic cancer in surgery. But I will go further because there will be a lot to discuss about. So it's not a disclosure, but it is sort of an alert for everyone. Everything we are going to say and show about surgical treatment of oligometastatic PDAC is actually, for the moment, outside any existing guidelines. And this is because at this time, if the main aim of us as pancreatic surgeon is to provide our patients the best option for cure, at this time there is no evidence to support the fact that this kind of surgery can bring and can avoid the risk of surgery, which is different from oncological radical surgery. It avoids the risk of early and late recurrence, the fact that our patients may die from the disease or die for postoperative complications. We can impact their quality of life, providing them for what is defined nowadays as futile surgery. So we really fear the risk of giving the wrong treatment to the wrong patient. I say that we are navigating outside existing guideline, and this is for sure true until the edition of 2024, because new edition of NCCN guidelines seem to open a little room for treatment in metastatic PDAC, which is different by systemic chemotherapy. And if you see here, the gold standard treatment, of course, at first diagnosis remains systemic chemotherapy, but in those rare cases of no progression of disease or stable disease after a prolonged course of chemotherapy, you see what is one of the options, metastasis-directed therapy at high-volume centers. And this really makes a difference from everything has been said until now. And they specify in rare circumstances when patients have indolent or oligometastatic disease, they should be referred to a high-volume center to be evaluated, not to be treated, but to be evaluated for possible metastasis-directed therapy. Some general consideration on PDAC, of course, it is considered, as we all know, a metastatic disease since the first diagnosis, even in those early stages. Early progression of disease can still occur after resection in early stages. But we all know that, but we want to make it to surgical resection for all, because at this time still surgery remains the only chance for cure or for prolonging survival in our patients. We also know that surgery alone is not enough. Systemic chemotherapy before or after or both has always to be associated with the surgical treatment. Some specific consideration on metastatic PDAC. It's different, unfortunately, from all the others. Metastatic solid tumor of gastrointestinal tract represents almost 40–45% of new diagnoses. Any treatment at this stage of disease is considered as a palliative treatment, and a surgery intended as curative surgery is not an option for these patients. We know some factors affecting prognosis in PDAC. Receiving surgery is one of those, receiving adjuvant chemotherapy as well, nutritional status of our patients, a systemic inflammatory index, and referring to high-volume surgical centers. These are all prognostic factors. So what about stage? We can say, with all the advances in systemic chemotherapy and multi-agent chemotherapy, that now the stage of the patients at the diagnosis is not the only predictor of prognosis. Of course, if we deal with the metastatic PDAC, this is what we have to face. This is what we have to say to a young patient, 45 years old, 60 years old, or 50 years old patient coming to our clinic with a diagnosis of a metastatic PDAC. So this is the reason why we are exploring other new possibilities for them, because these results are for sure not satisfied. So I'll jump into this new concept of oligometastatic disease, also for pancreatic cancer. As we usually do, we borrow concepts from other specialties, from gastric cancer, for breast cancer. So we try to develop the same concept also for pancreatic PDAC. Actually, the very first definition of oligometastatic PDAC comes from 1995, so quite a few years ago, but it took a long time to be defined and to be well established, and if I can say, to be accepted by the scientific community. And from 1995, we jumped to 2019 with this paper from the British Medical BMC Cancer, and they tried to combine some characteristics of PDAC that combine at the same time simultaneously could identify what they call oligometastatic PDAC, a limited disease, limited burden of disease, CA 19.9 below 1,000, and a single organ as a metastatic site. So patient who had all these three factors together could be defined as oligometastatic. And you see all the different survival. The upper graph is representing the different site of a metastasis, single site, single different site compared to multi-metastatic site. And the second, the below one, represents the difference in survival between the all single site metastatic patients with the multi-metastatic patients. And putting all these characteristics together, limited disease, CA 19.9, and single organ, you can see the difference in survival between the oligometastatic patient and the non-oligometastatic patients. Clearly an advantage. We go further with the paper published by Carl Leonard from the group of Oliver Strobel, who's going to be one of the next speakers. This is more recent, and they are going a little bit deeper into the definition and into the selection of those patients that we can consider metastatic, so who could benefit from a more aggressive treatment. Of course, they consider the number of metastases, number of affected organs, size of the lesions, CA 19.9 value, and this is the new concept, treatment possibilities. So for liver, it's 3 metastases or less, and for lung is 2 metastases or less, and they should both be technical resectable, of course, in patients with good performance status. And then this carries us to the concept of conversion surgery. This is not because of this paper is not cited because of the quality of data, because we all know what a SER database is. So it compare a lot of patients, a big number of patients, but with the poor quality of the collected data. But this is just to highlight the fact that liver metastatic PDAC and metastatic PDAC are a huge number of population of patients. So if even a few of them could benefit from a more aggressive treatment, it's going to be a not negligible number of people. Conversion surgery clearly demonstrates the fact that invest resources in treating those responders brings a benefit to survival. And this is comparing in this paper what is defined unresectable PDAC for locally unresectable disease or for metastatic disease compared to resectable disease. And what is highlighted by this paper is that even in more advanced stages, so locally advanced or metastatic PDAC, the difference is done with resection compared to no resection. And again, between distant metastatic patient or locally advanced disease, they did not find any difference in survival. And at multivariate analysis, pathologic complete regression, R status, and nodal status were the main predictor of survival for these patients. It is, sorry, I don't know why it's going. And it's important to see that these are prognostic factors even in resectable cancer. Of course, as usual, no difference among the therapies the systemic therapies these patients undergone. And again, other factors related to prognosis in conversion surgery, always considering unresectable PDAC, both for metastatic disease and locally advanced. On the graph on the left, you can see the difference in those patients with the same stage of disease undergoing conversion surgery compared to those who did not. And on the other side, you can see both metastatic and locally advanced patients in the different curves, those who underwent to conversion surgery and those who did not. And still, in both cases, you could see the benefit for prognosis in those patients with advanced disease who underwent conversion surgery. Of course, this is a selection bias from a surgical series, but it has a meaning. Metastatic PDAC to the liver is, of course, the most frequent case in PDAC. There has been a conceptual shift from upfront resection of primary and liver metastases to resection of only those patients who seem to be responders to systemic chemotherapy, and also who has a limited disease to the liver. You can see the two images on the side. Of course, these two patients have a similar stage of disease. These are both liver metastatic PDAC, but you can say that they look a lot different. Only two liver lesions and a liver on the other side with a higher burden of disease. So these two patients, they are supposed to respond differently to systemic chemotherapy. And here the concept of oligometastatic disease. So we should target our patients to receive the treatment they are most reasonably supposed to respond. This is one of the first meta-analysis and review from Stefano Crippa from Milan. And the most important conclusion from this analysis was that in the new era of multi-agent chemotherapy, surgery can be considered only in selected patients with prolonged biochemical, radiological, and clinical response to primary chemotherapy. That remains the treatment of choice. Unfortunately, this analysis is based on retrospective study, mainly coming from a single center experience. We had experience in my center in Verona about metastatic PDAC. We were very strictly selecting only patients who actually radiologically responded 100% on the liver, so complete disappearance on liver met from radiology at red staging. And we treated them with surgical resection of the primary tumor. And we were very surprised about the results we had in survival. Of course, these patients were selected after a long story of complete and persistent response to chemotherapy. So 56 months of median overall survival and a longer progression-free survival too. We could not identify any factors related to the survival. We tried a few years later, and what we saw was that the need of a vascular resection, a high inflammatory index, and a poor nutritional status actually were considered as negative prognostic factors for these patients. I'm going to this conclusion. This is the most recent meta-analysis of this role of surgery in metastatic liver metastatic PDAC. 14 studies, all retrospective. The conclusion is that we need larger multi-center randomized control trial. And this is what is on the table now. We are doing a prospective randomized study in Italy, our center in Peschiera and the University of Verona. This is going to be a multi-center international center. All patients after a long course of chemotherapy will be randomized, if a stable disease, to surgery or to continue maintenance therapy. This is another trial from the German group. It's called MetaPank. 270 patients to be randomized. The aim is to reach R0 resection, and they will consider strictly therapy target to the metastasis as well, not only surgery, but even ablation and radiotherapy treatment. This is a first trial, the EXTEND trial, that will lead to another, the following one, the EXPAND trial. And by summarizing them, the EXTEND trial will mainly treat patients on the liver met with the RFA or stereotactic therapy by enhancing the fact that ablation of the liver mets could enhance an immunomodulated response from the patient, helping to react to the systemic disease as well. I'm getting to the end, so maybe in this case the ablation can have a higher meaning than surgery for metastasis-directed treatment. So we slowly went from upfront surgery of the primary plus metastatic disease to neoadjuvant followed by surgery on both sides, to multi-agent neoadjuvant followed by surgery only in those who responded, to the definition of oligometastatic disease responders to chemotherapy, and to select those patients responded with oligometastatic disease and to treat directly the metastasis also. So oligometastatic PDAC represents a separate entity, but maybe it's not only about the liver. Systemic chemotherapy remains the treatment of choice for these patients, and only prolonged responders can be considered for more aggressive treatment. We should investigate the role of metastasis-directed treatment. We still have a lot of open questions for these patients and new concepts as well, like the oligoprogression patients, so those who progress after surgery slowly and not with a systemic spread. So this is my last slide. Pancreatic cancer, taking it from a paper from John Neoptolemus dated 2016. Pancreatic cancer and FOLFIRINOX, and I would say, and chemotherapy. Should we resect all responders? I think the answer is yes. And thank you for your attention.